So our keynote is about to take the stage and bring it all home with a message that will challenge, inspire, and energize us for sure. So lean in and get ready for this final session. I believe it's going to spark your next big idea, or it certainly has the potential for doing that. So I'd like to introduce you to Dr. Brian Klepper. He's the co-founder and chief strategy officer of Employers Clinic Commission and a leading healthcare analyst. He advises on advanced primary care, high-performing specialty services, and healthcare risk management. Over the past decade, Dr. Klepper has identified top specialty healthcare organizations that improve outcomes and reduce cost. As a vocal advocate for reform, he's also influenced policy changes and legal actions. He contributes to healthcare publications, serves on advisory boards, and received an award from the Health Rosetta in 2023. I'm tired just reading that. He's done a lot of pretty special things. So, with that, I want to welcome to the stage Dr. Brian Klepper.
Good afternoon. Thank you for coming. I have a lot to talk about with you, and let's get right into it. You've all been to 100 meetings like this, and at these meetings, people stand up and they say, I'm going to show you how to get better health outcomes at lower cost. That's not what I'm going to say. What I'm going to say is, unless we work together, not as individual groups, but we come together in a bigger mass and we exert the collective leverage that we're capable of through our heft, we have no prayer of having a better deal in healthcare. We've got 80 years of the current system in the rearview mirror. We know what the answers are. We know whether our system works or not. We now have to fix that system because it is the most important threat to our national economic security, except for the problem that we're dealing with recently, which is the loss of democracy. That's more important. What I want to show you is sort of where we are first, and then move real quickly into the components of a fix. And my goal here is to convince, especially the employers in the room, that they have to find a way to come together. All of us have to work together. So with that, the state of the system. America has a for-profit driven system. Everybody in American healthcare makes money and lots of it. And even the not-for-profits, they all are for-profit in everything but their legal name. And that's a problem, as it turns out. Since 1952, healthcare inflation has grown 3.7 times as fast as the rest of the U.S. economy. On a continuous basis, it's drowning us. And now more than 40% of Americans have medical debt. 12% of Americans owe more than 10 grand. And 1 in 5 adults between 18 and 29 needed to borrow to pay their health care bills in 24. 2/3 of personal bankruptcies are at least partially associated with health care bills. And more than half of us who have hospital debt also have insurance. If that's not an indictment, I don't know what is of a society. You'll excuse me. I have a, what shall I call this? Not quite a dread disease, but almost. And so I get a little uncomfortable, and I'll feel better if I can walk around a little bit while I'm talking to you. Thank you for putting up with that. This chart shows the growth in healthcare as a percent of household spending. Dave Chase, the guy who founded the Health Rosetta, has built a career on the idea that healthcare has stolen the American dream because all of the gains that American workers have obtained have been drained away by healthcare costs. So the employees haven't benefited at all. It's another real issue. And this chart, I think, is particularly important. This chart says, here's where all the other countries in the advanced world are in terms of their healthcare performance and their spending. And we're way, way down at the bottom and way out to the right. What this chart shows is that the US has the lowest healthcare value by a long shot in the world. And there's really not any way to argue against that. So here are the things that we need to be thinking about. The healthcare industry can invest unlimited funds into dominating policy and regulation. They have captured the regulatory environment. Congress does what the healthcare industry wants and says because the healthcare industry buys them off with lobbying dollars. So it's very hard to fight against that. So we have to, if we're going to fight them, we have to fight them in the marketplace. We have to give purchasers a better mousetrap, a better deal, and then we've got a chance. Are there practical ways to get to better health outcomes at more reasonable cost? Yes, and I'm going to show you some, but there are lots and lots and lots. What'll be required? We need the purchasers to come together, and we need to get the buy-in of the brokers and the healthcare advisors so that they're not taking money from the health plans under the table, which they've been doing for many years, and the CAA has finally made that accountable. So what do we do? What are the elements that we need to have a better system, and how do you get at them? First, it's real important to say out loud that what healthcare is about is the management of clinical risk and financial risk. That's it at the bottom line. It is a risk problem. If I've got a patient who is sick, I need to be able to get access to the tools that can make that patient better, and in a way that we can afford to have the next patient sick. We don't have that currently, but that's the grail to be able to do that. We're going to have to build a new system. We have to pay attention to what the rules of the existing system are, and we need to avoid the pitfalls. We need to not step on any landmines. That's a very serious caution, because it's easy to do the wrong thing when you're not quite sure how it all works. We need purchasers who believe that there is a better way. We need a critical mass of self-funded purchasers, unions and employers, who are so frustrated with the existing system that they're finally willing to ditch the legacy system that controls us now, and instead use proven high-value performance capabilities. So when I say that, what I mean is we need to find high-performing specialty services. We need to work with primary care organizations that aren't giving us 1975 primary care. Primary care offices should be operations that become platforms for managing clinical risk and financial risk anywhere that it occurs in the continuum. The primary care doctor isn't just there to do wellness prevention, minor acute care, chronic disease management. He or she is there to be the quarterback, to be the patient guide and advocate wherever the patient is in the system, so that the specialist doesn't make a decision that affects that patient without also consulting the primary care physician. We need to get back to that. So there are 5 challenges that I think are important. One is mobilizing the purchasers to collaborate. That's what you're here for today. Modern analytics that can support decision making. You should be able to send the alliance your data, your claims data, and if you have a clinic, the EHR data from the clinic, and you should be able to send it to your alliance at a very low cost, and the next day or the day after, you get back a report that says, here's where your population is weak, and here's where it's strong. Here's the behavior and the performance of each of the specialists taking care of your patients. Here are things you can do that will make better performance for the health plan. And here are vendors who we think are high performers, and we show you here. We've modeled out your costs if you use this vendor, and they will guarantee this level of performance. That should be readily available to you. Currently, I'm not aware that it's available from anybody. My team is working on it, but we're not quite there yet. We want to empower primary care as advocates and guides. Primary care physicians and the whole clinical primary care team, they are managers of complexity. That's the way they think of themselves. They're not the dumbest guys in the medical school class. They're the smartest guys. And think of the task that a primary care physician has. It's always a worthwhile exercise. The primary care physician in most settings, I've got a close friend who is an internal medicine physician at Johns Hopkins in Baltimore. She gets 7 minutes with a patient. And in that 7 minutes, her job is to identify what's going on with the patient that she's never seen before. It can be hormonal, it can be viral, it can be bacterial, it could be anything. And she's got to make a call on what it is, and then make a decision whether she's going to take care of it or does she send it to somebody else who's going to take care of it. That's a pretty difficult task. It's very formidable. We need to be able to identify and vet everybody who's a high-performing vendor. High-performing here means something very specific. Everybody and his wooden-legged brother that I work with in my day-to-day life tells me that they're a high-performing vendor. And it isn't so. So what I'm looking for healthcare organizations that can demonstrate with longitudinal data, long-term data, that they consistently deliver measurably better health outcomes and or lower costs than conventional approaches, and particularly in the high-value niches where the money is. We're not talking about wellness here. Apologies to anybody who thinks that that's the answer. There's no data to support that that's the answer. Wellness is like kissing your sister. There's just no thrill. But we're talking here about we're talking here about management of chronic disease, particularly cardiometabolic chronic disease. So think of all of the areas that includes. They're talking about high cholesterol, high blood pressure, diabetes, heart failure. The metric of interest with chronic disease is what's called control. If the patient is being managed, if you go to the patient and randomly test them, are their numbers within acceptable limits or not? If they're not within acceptable limits, they're out of control. Right now, the CDC says that 44% of American adults who have high blood pressure are under control, which means that 56% of American adults with high blood pressure are busy having heart attacks and strokes that they didn't need to have in the first place, and we're paying for that. We do a terrible job with managing chronic disease. The 44% number is the real number for high blood pressure, but 10% of diabetics are under control. 1.5% of heart failure patients are under control currently. And this is a manageable problem. If you go to the doctors and you say, "Why are you so lousy at this?" They'll say, "Oh, the patients don't do what we tell them." But it turns out that's not true. It turns out that the real answer is that to accurately prescribe for these complex conditions, the doctor has to go through juggling as many as 50 variables at any one point in time, and that's beyond the capabilities of human cognition. It just can't be done. And so in a sense, it's not their fault, but it turns out that is a problem that machines can deal with. And it turns out that when AI has been applied to the chronic disease problem, that the 44% control for high blood pressure goes to 94%. And that's been validated a number of times. So there's hope out there. Let me move on to other things. We have to identify the high performers, and we have to find a way to integrate them in with each other, and make them integrate with primary care. And we have to be able to do it in a transparent way so that everybody feels like they're being treated fairly. And that's something that that's gonna be on our list in the near future. First of these challenges is the untapped collaborative market power for healthcare purchasers. How to get employers to come together. Well, it's hard to do because you have your group, you have your employees' characteristics with their families, and you were used to thinking just about your group. So we've got to find a way to get beyond that and to work together so we can go to the Uniteds of the world, the Aetnas, all of those guys, all the Bucas, and say, no, we want a better deal than that. And we've got this many lives, and this is what we think we should have. So far, American business has not been willing to do that. And I'm about to say something that is going to sound negative, but I don't mean it that way. Look at what the business health coalitions in the country have done. They've been around for 40 years. The really big ones, the Health Transformation Alliance, the Purchasers Business Group on Health out of San Francisco, the Business Group on Health out of Washington. Is there any data that demonstrates that if you join a business health coalition, you demonstrate better health outcomes and or lower cost? Is there any data about that after all these years? There's not. And so that raises the question of what is the value prop? I think that's the moment that we are at the Alliance. I think that the employers who belong to the Alliance want to do more. They want to actually get out from under the yoke that healthcare has represented to their businesses. and it's high time, and it's doable. Coalescing will require finding common practical value in an entity aligned with their interests. Everybody's interests count here. Everybody's got to give a little, and they need to get what they need. So I think this is absolutely key. Modern analytics. Modern analytics should be easy to look at. They should predict the things that the reader wants to know and make that easily accessible. And they should be able to make decisions just by looking at the dashboard. They need to be very intuitive and easy to understand, and they need to be attractive so that they're not a pain in the neck to look at. That's what we need. Worksite clinics. I used to own a worksite clinic company, and I learned a lot about the management of risk in that process. And now I advise clinic companies and I advise employers. And right now, the on-site clinic industry is weak. They've got a lot of businesses that work with them, but they're not delivering the kind of value that they could because they've only gone as far as the 1975 primary care model. They're not going after aggressive management and new tech models of managing their different kinds of risk. And all of those different kinds of risk represent targets, and each one requires a different arrow. So that's where we are with that. But we can come together, we can hold their feet to the fire, and they'll do exactly what we want because they want to stay in business and they want to thrive, and they are potentially the most evolved and important medical management function in the health system today. There is the issue of direct primary care. As much as it pains me to say it, most of the organizations that I've encountered that work in direct primary care, they're founded by doctors who were working for hospitals and they were feeling controlled and compromised. They've come out, they spend more time with the patients, which is a really good thing. But they don't invest in infrastructure that would allow them to manage populations in a better fashion, and that we all know would allow that. So they need to up their game, just as the advanced primary care organizations, the Crossover Health and Marathon and all of those organizations, they need to up their game too. You would think I would know these all in my head without having to look at these, but who knows? A well-run advanced primary care clinic should deliver a meaningful return on investment. And here, after all these years working on it, I've been working in primary care with on-site, near-site clinics for about 15 years now. I think that ROIs in the range of 7 to 1 and above should be what everybody's expecting, and they're eminently doable. Eminently doable. Speaking of return on investment, another problem to keep an eye out for with the worksite clinics is that most worksite clinics have now taken private equity, and the cost of that money, the cost of those investments is very, very high, and they're passing it along to you and you're not getting any value out of that debt service. So you want to favor organizations, frankly, that have not taken money from private equity or venture capital if you at all can. The high performance topic. So about 10 years ago, I got the bright idea that I thought I would find really great healthcare companies. And I began to ask around and say, anybody know any of these? Does anybody know companies that just knock your socks off? And I began to find them. And then people started calling me. And they started saying, they'd open up the conversation. I'd say hello, and they'd say, I heard that you're looking for really great healthcare companies. We're one. So I'd say, well, hang on. Let me ask you some questions first. But look at all of these areas. So advanced primary care, cardiometabolic care management, complex disease management, we're going to talk about that. Musculoskeletal disorders. Musculoskeletal disorders are 17% of the money that you're spending in healthcare. And there's an organization out of Tallahassee, Florida, that will guarantee a 25% reduction in your musculoskeletal spend on the patients they touch. That translates to a guaranteed 4 to 6% reduction in total healthcare spend, which is a big number. But it's really going to give you more like an 8 to 12% reduction in total healthcare spend because they're guaranteeing half of what they know they're going to deliver. And they know that because they've got 5 million records already of past patients. So they know they have enough experience that they know that. And so pulling in that vendor to work with you is a good idea. Surgical management is another area. Maternity is a really big area, and we spend a lot of money there. Drug management, you can't say enough about drug management, and I'm going to talk about that again in a minute. Pharmacogenetic profile. Can I have a show of hands of people who know what that is? Pharmacogenetic profiling? So maybe a third. Pharmacogenetic profiling is this incredibly interesting technology that came out about 15 years ago. And the way it works is that you take a swab and you do your cheek and you send it into a lab and they look at the genome. So this technology came out, and what it shows is it gives you a list of the drugs that patient can and cannot metabolize. So if you're on certain drugs that you're not able to metabolize, you can get rid of those drugs because they're not doing you any good and it's costing a lot of money. It also prevents adverse events because you can take drugs that conflict with your own metabolism or with some other drug that you're taking, and without having known it. Nobody in the U.S. health system has picked this up and started to use it, but there's a really interesting study that took place in Kentucky with school district retirees. There were 30,000 lives in the study. 5,000 of them had the profile, and the other 25,000 didn't have the profile, and they were matched cohorts. They had the same demographic composition. And what ended up happening was that the group that had the profile and that gave their doctors access to it, their total healthcare spend dropped by an annual $2,625 per senior per year. If you take that number and you say, well, what would happen if every Medicare patient had one of these profiles? The answer is it would save America $171 billion a year by doing this one thing. So if I were running a company, I'd have everybody in my company do the one time in their lifetime $300 test for the profile, and then the $6.99 or whatever it is monthly, so that it's available remotely, mobily, to the doctor, to the pharmacist, to the health plan, to the patient, and so on, and it can be used. Nearshore centers of excellence, you suddenly need an expensive procedure. Maybe you should go to Health City, Cayman Islands, which is in the Cayman Islands, more remarkably, and where they have arguably some of the best care in the world. And the cost is going to end up being one-fifth of what it's going to be here for top quality care. That organization and ones like it, but that particular organization is owned by a hospital system out of India, and they are the real deal. But there are lots of centers like that, and that should be a resource for you. Claims review, imaging management, large claims resolution. Here we're talking about you've got a $25 million claim, and you hire somebody who will work the claim with you. They'll get it down, and you'll pay $7 million instead of 25 or something like that. It's a big part of the industry, and it matters. Second opinion is also important. These are all important areas because they all represent huge amounts of money, and if you can impact those, you can go far. What I want to do here is I want to talk about the kinds of people who start these companies. The people who found what become high-performing companies, in my opinion, they all look and sound alike. If you bring them all and put them in a room together, they all are mission-driven and passionate. They all are data and evidence-driven. They're real big on data. They have very high subject matter expertise in the niche they're working in. You know, if you're talking about cancer care or rare disease care, they know everything there is to know about it. At the end of the day, they have found a problem, and then they've deconstructed that problem, and they have found a solution over time. They've put a solution together, and the solution looks completely different than what everybody else in the country is doing on that problem at that time. And they're dedicated to continuous quality improvement, and they're always willing to put financial guarantees on their performance because they're so intimate with the process and so confident of what their abilities are. In my opinion, those are the criteria that you should be looking for when you're looking for partners on particular kinds of problems that you've got. Let me give you an example here on the chronic disease management. If you look at the companies that provide diabetes care, you'll find that their common denominator is that they all use coaches. Well, the problem is, and the coaches don't talk to the doctors. The problem is that if somebody's not succeeding with their diabetes care, it's very unlikely that a coach is going to be meaningful to them because they probably have a metabolic problem, and the doctor needs to be talked to about whatever the pharmaceutical regimen is, and so on. All of the cardiometabolic chronic diseases are related. They all have the same reason to emerge as a problem. So there is a very interesting physician by the name of Bill Besterman who lives in Greenville, South Carolina. If you met Bill and talked to him, he's like an old shoe. He's just as relaxed and calm and smart and sensible as a human being could be. And over time, he's become a champion of what he calls optimal medical therapy. Patients that are on optimal medical therapy, diabetes patients, they have a quarter the number of heart attacks that the regular population does. They have a fifth of the strokes, and they're more likely to survive a heart attack if they have it. I mean, it doesn't get any clearer than that. The classic diabetes management problem was no, I don't want to talk about that. They're a company that ultimately sold for $18 billion, and then everybody realized that nothing they did worked. And that's the danger, is that somebody seduces entire populations, and there are ways to avoid that. It's important to understand that chronic disease, which is our single biggest medical problem, chronic disease eats up about 45% of all the money in healthcare. And it's a disease that is fairly low intensity, but lots of people have it. And then there's the flip side of that. There are the complex diseases. Those include the cancers. They include neurodegenerative diseases like I have, Parkinson's, Alzheimer's, ALS, diseases like that. The complex diseases are interesting because so many of them are so expensive that all the complex disease patients, they show up once in a blue moon, but when you got one, you know, you're in it for millions of dollars for sure, so they're brutal. In addition to that, there aren't very many people at a local level who know much about most rare diseases. You know, so finding expertise is real difficult. There's one of the organizations that I work with has specialized in putting together teams who deal with people who have rare diseases, and you pay them nominal amounts of money to track all of the people in your population, until somebody comes up with one of these conditions, and then they step in and they manage these patients. They see what options are available for them, and then in addition to that, they try to match these patients with clinical trials that are going on somewhere in the country. And the reason for that, there are two reasons. One is, if you go into a clinical trial that's focused on a particular rare disease or common disease, like certain kind of cancer, and we know now that there are like 1,000 different kinds of cancer, that if they go into that clinical trial, the cost of the drugs stops being on the responsibility of the employer, and it becomes the responsibility of the company that's sponsoring the clinical trial. So you can get tremendous savings on each of these patients just by working with them. The way I think of it is everything in healthcare is expensive, but this is in for a penny and out for a pound, really. What this slide shows is that a third of all the money in commercial healthcare is driven by 6 to 10% of the population. And in Medicare, it's 40% of the money is driven by 20% of the population. So these are rare diseases, and by 2030, it's projected that these conditions are going to cost more than $1 trillion just on their own. I mean, so this is where we're going with cell therapies and gene therapies. They're fabulous, but they cost immense amounts of money under the current structure. And then I mentioned the pharmacogenetics. It's important also that I tell you that I originally was going to tell you who these vendors were, but I don't want to imply that I'm selling anything or that I'm advocating for a particular vendor. I do advocate for particular vendors because I have vetted what they do. And my job, I think, is to stand up here and say, here's why this organization is special. But if you want to know who they are, you come up to me, we talk, then I'll tell you who they are. Just to be clear. There's a problem with point solutions like we're talking about. One of the problems is that a point solution, by definition, is outside of the network that's brought to you by your health plan. And so that means that managing that contract needs to be done by somebody in your benefits or HR office, and typically that person is low on the totem pole, doesn't have an awful lot of experience with managing, something that's as peculiar as chronic disease or whatever. And if they've got 4 or 5 different contracts to manage, that eats up an entire FTE. So it's expensive, and it's time consuming, and it's hard to make it work. The other problem is that I can go, the guys in Tallahassee who did the musculoskeletal management, they can come up to an employer and they can say, I can save you a guaranteed 5%. We'll promise we'll pay you back if you don't get that. We'll make it up. They'll guarantee that, but the benefits manager is going to go 5%. It's like, is the juice worth the squeeze? So they'll go, nah. For that, Cigna has a musculoskeletal management program. I'm sure it's almost just as good, and so they don't do it. So it's hard to make it go forward unless you aggregate them. So let's say that instead of you and you saying I want to use this vendor, you bring all of these vendors together that are the high performers into one group, and you say, will you go at risk for the population that uses your services? Will you go at risk for the population that needs your services, and so on? And the vendors will say yes, because otherwise they don't have a shot at succeeding in the market. That's where we're going to go, and we're pretty sure that'll work, because at the end of the day, what you get. That's the slide I wanted. That at the end of the day, you aggregate the savings that you're going to get across these point solutions, and it ends up being a big number. I mean, it ends up being, it's fairly straightforward to guarantee that you're going to drop total healthcare spend by 20% when you've got all of these levers to pull, and that's the game that we're in the middle of. Does that make sense to everybody? Anybody object? Oh, I can't see if you do anyway, so the hell with you. Okay. This is true. We've got an entrenched structure. I would imagine that the brokers are not enjoying this, pontification very much. But we've got to find a way to change, because we're doing the same thing over and over, and it isn't working. And so the high performing vendors coming together, they've got to be able to make the employers an offer that they just can't refuse. And to my mind, that would sound like this: if you will work with us, we will guarantee that in the next 2 years you will pay 25% less. We will financially guarantee that you will pay 25% less than you currently pay now on your health care, with better health outcomes on the following metrics. And that should be something they'll either go for it or they won't. If they won't move away from a Blue Cross or an Aetna or a Cigna or an Anthem, then we're stuck with the same system. There was an article in The Economist last year that was talking about how ridiculous American healthcare is. And one of the things they said was that 45% of all of the money that we spend in US healthcare goes to 9 companies. And all of these companies provide no care themselves. They're insurance companies, or they're pharmacy benefit management companies, or they're stop-loss carriers, or they're wholesalers of drugs or whatever, but they're not delivering care, and they eat up almost half of all the money. And the half of the money that they spend is equivalent to what everybody else in the world is spending for all of their health care nationally, because we're spending double what everybody else pays. And we've got mediocre to poor results. So there are a lot of healthcare organizations out there that are delivering no value at all to us, and we're paying through the nose for them, and we've got to find a way to fix that. And coming together is the way. Let me say it this way. There is only one group that is more powerful and influential than the healthcare industry, and that's everybody else. And that's what I would, if I could get on my knees and beg, I would do that. That's what we have to do. We have to find a way to come together and use our collective leverage against the healthcare legacy system that we've got. While we're on the topic, for 5 years, I founded, and then now I moderate, which is something like being the hall monitor, a listserv on healthcare value and high performance. I am delighted to tell you that there are 1,200 healthcare professionals. These are benefits managers, they're benefits advisors, they are innovative vendors, they are doctors and attorneys, and many of them are very prominent in their fields. And every morning I wake up and I send them articles from different newspapers and magazines and wherever I find stuff, and I send it out to them, and then they have spirited discussions about what it means and what's right about it and what's wrong about it and so on, and it's very helpful. There are lots of people who will tell you it's the best thing that they've got. I don't have 10 minutes left to say. If that sort of thing interests you, I would want to say you need to get more fun in your life. But if that sort of thing would interest you, there's my email address. Send me a note, and I'll enroll you. If you don't like it, you send me back a note, and you say, Brian, you seem pleasant enough, but this sucks, and take me off the list, and I'll do it. It'll be fine. But I think you'll like it if you look at it. This is just about me, which doesn't matter. Thank you, and thank you very much for being patient with all the things I've thrown at you. I have thrown a lot. If anyone would like to talk about any of this, we're all ears. Thank you.
Nicely done, Brian. Can you hang out for a minute or two?
Yeah, sure.
Excellent. So again, thank you for your insight into the very complex and difficult space that we're talking about today.
It is complex and difficult.
And your insights are unique. I don't know that I can tell you that I haven't heard all of the insights that you presented here today, and I've been at this for quite a while. I'm sure that our audience is learning too. So,
yeah, but I made a lot of that stuff up.
I saw footnotes on one or two slides. But if you've got questions for Brian, I'd like you to take the time now to either ask those via the QR code or step up to the mic, and let's use the time that we've got here with Brian to press a little bit on some of the topics that he mentioned.
If a company is doing an RFP for a new on-site clinic partner, what is one question you would ask them?
What is the question I would ask them? What percent of the population of employees and dependence can I expect will your program will generate? Clinics are the purpose of a clinic is to capture the patients so that you can manage them. If you're only getting 20% of the population in, you're wasting your time. And so the clinic company ought to be able to demonstrate that historically they've been engaging to the population, and they've gotten them successfully into the clinic. That's one critical question. There are a lot of critical questions. Another one is who's leading the clinic clinically? Is it a physician? Is it a nurse practitioner? Is one better than the other? Well, nurses are cheaper. They're not trained as well as physicians are. They tend to refer more than physicians do. So there are trade-offs, always. Anybody else? No?
Have you seen vetted methods to determine ROI of on-site clinics? How can employers access them?
How did you phrase that with the ROI? In the calculating the ROI?
Have you seen vetted methods to determine
vetted
ROI?
method. Yes. Yes, our company does an ROI calculation. We're glad to show it to people how we do it, but it takes into consideration all of the costs associated with mounting that clinic and what impact that clinic has had on the health plan and what the returns have been. So we're pretty comfortable with it. When I was an owner of a clinic company, it was my job to do the reporting every quarter, and I felt comfortable with that because I knew the math and so on. But my partners would fudge. They go, well, we avoided them having this, adenoid surgery, and that would have been $8,400. I said, well, yeah, but that's like faulty reasoning. That isn't the way. What in the real world happened that allowed you to save money or not save money, and what can the employer reasonably expect? And that's a serious question. That's the place where you have to start. So the first thing we have to know is where do all the numbers come from, and what do they represent? Anybody else? Nobody going to stand up and go, "Are you kidding?" Well, thank you. You've been patient, and I appreciate it. And it's been a wonderful conference. So thank you very much. And let's thank the Alliance.
Thanks, Brian, for your time. Appreciate it. Greatly appreciate it.
Yeah, I appreciate it.
So, and I appreciate you all giving Brian a warm Wisconsin welcome. We did turn the warm weather on for you.
Yeah, in Florida, it wouldn't be that kind of welcome. It would be hotter than that.
Very good. Well, again, you taught us how to think bolder, act a little bit more decisively. Some of the things that we need to be contemplating, with regard to the macro picture of healthcare management is very intriguing. And so, again, if you want to continue the conversation with Brian, he's given you that access and that ability to do that. You'll be around for a few more minutes before you have to head out.
Yeah.
Okay.
Yeah, and honestly, I think that if you have the appetite for it, and the Alliance feels the same way, I think that conversations about what is possible to do should be convened, because it's a serious topic and it needs to be seriously considered. So there. Okay.
Excellent.
Thank you.
Very good. Thank you. I appreciate it so much.